Okay, well, I want to welcome everyone to our webinar today. I'm very excited to have our panelists share. We are National Aging in Place Council's San Francisco Bay Area chapter, and my name is Sarah. I'd like to introduce AJ, who is also one of our members and who runs Comfort Care Home Care Organization. And he'll be introducing a speaker today to share information with us about hospice and palliative care. And I thank you both so much for being here, for your time and ability to share with everyone.
Thank you, Sarah, for the introduction. Today, I'm very excited to have Dr. Kuljeet Multani with us. She is a Bay Area physician who is triple board certified in family medicine, hospice and palliative care, and hospice medical director certification. Currently, she is a palliative care physician with Palo Alto Medical Foundation and a hospitalist at Stanford Health Valley Care in Pleasanton. She is also an associate medical director at Hope Hospice, a nonprofit organization that is serving the East Bay community for over 40 years. Good afternoon, Dr. Multani. How are you doing today?
I'm doing well, Ajay. Thank you for the warm introduction.
If unfortunately we face any serious illness, it can be very overwhelming. So let us start from a common person's point of view, and maybe you can explain what is hospice and what is palliative care.
Absolutely. So I feel like those words are so interchangeable, and a lot of people find them both, really a mirror image of each other, which is not necessarily true. So palliative care is essentially for patients who have been diagnosed with a serious medical problem. So no matter what their age, they've been diagnosed with a serious medical problem or have multiple medical problems or are simply getting older and are having increased difficulty in taking care of their physical and their mental and their social needs. So very, very apt for this platform that you have here. Palliative care and hospice are both purely about quality of life. So, but palliative care is essentially quality of life while trying to extend your quantity of life out as much as possible. An example in this case might be a cancer patient. So somebody who is going through some really aggressive treatment may have issues with how they're doing on a daily basis. So quality of life essentially can mean many things. It can mean physical in the form of pain or appetite or energy levels. Anything, like I tell my patients, from head to toe that they may be going through as a result of the disease or as a result of the disease treatment. So cancer is a classic example, but you can have the same in diseases like congestive heart failure, emphysema, where every day the patient has to be on top of their needs in terms of diet and checking the blood sugar levels, let's just say, or fluid intake and the medicines that they're supposed to take. So that can by itself be very, very overwhelming. So that's the physical part. And then you go to the mental part. And the mental part of diseases can be challenging because there are many, many parts to this. This can be really how your mood is because of what is going on with you. It can be psychological, so a psychological effect on your body and your mind. It can be social. So something that we group together and call psychosocial effect of having a disease. It can be emotional. It can be spiritual. Now, all of these are very different terms, but really what we're talking about is when the patient starts to think about mood, really being depressed and sad and tearful about what's going on with them. They can start to think about it from a psychological, psychosocial aspect. How am I going to manage myself when something like this is happening to me? The social aspect can also mean if I can't take care of myself, who is going to take care of me? And in that sense, the caregiving becomes a very, very critical component of this whole medical care. The emotional aspect of this. Why is this happening to me? The spiritual aspect of this. You start to question, did I do something wrong in my life that this is happening to me? So there can be so many components to this. So palliative care does nothing but provide very wholesome care which is both
Uh-huh.
physical, mental, and social for patients who've been diagnosed with a serious medical problem or multiple medical problems. Now, palliative care is really the time where patients are actually choosing to have treatment associated with their disease. So, if it's cancer treatment that they're going through, or some cardiac treatment or lung treatment, when it kind of becomes obvious that that treatment is no longer working for these patients, we
Mm-hmm.
want to start to try to focus on just comfort. So, purely quality of life issues versus quality plus quantity. And so, when it becomes purely quality of life issues, and we can estimate or guesstimate rather that the patient may not either have very long to live, does
Mm-hmm.
not have any treatment options, or is having too many side effects from those treatment options, even if they're responding to disease, we start to suggest and recommend what we call comfort care. The other more medical term to that is hospice. So, while palliative care can be something that patients can have for weeks to months to years, and we certainly
Mm-hmm.
have patients on our services who've been on our service for at least 6, 7 years even, and are finally showing decline or actually continuing to stay stable. Hospice is essentially, in insurance terms, for people who want to focus purely on quality of life and may have essentially less than 6 months to live. Though I will tell you, in the real world, that may not necessarily be true. While as we're just humans at the end of the day, and we can say, yes, in my estimate, you probably have a life expectancy of less than 6 months. We've seen patients be on hospice for much longer periods of time as well.
This is a very good way to describe and differentiate between quality of life and quantity of life. So, when people realize that the illness is very serious and there may not be a good cure, it becomes very difficult mentally, physically, and emotionally. So, can you please explain what challenges do you see patients and family members face and go through?
Sure. I think the most common challenge that I see with patients is that they feel that they have to figure this out themselves. So that's the biggest challenge. It can be really, really overwhelming. And a lot of patients will say, like, well, how do I do this? Or they're scrambling for support within their own structure by itself. But in reality, all they have to do is reach out to their doctors. And there is this whole team that I describe, and we all kind of work in equal ways. You know,
Mm-hmm.
no one is one less than the other in on our teams, as I describe it. Each one is plays an equal and very, very crucial role. But there is a whole team of medical personnel who are available and ready to serve the patient, especially when a situation like this arises. So I think that while the first reaction can be one of shock, one of denial, one of being overwhelmed,
Mm-hmm.
it is always good. The first reaction can be that, but I would always recommend my patients to reach out to the doctors and say, okay, where do we go from here? How can you help us? And it is important to realize that doctors are not just there for just giving medications. There are so many resources that we have available that we can provide. For example, on the palliative care team side, we have not just doctors and nurse practitioners who actively take care of patients, but we have nurses, we have social workers, we have our care coordinators, all of whom are working. We have chaplains, we have a pharmacist, we have home health therapies. All of us are working very, very closely together to coordinate the care and manage the care for these patients. So, a lot of times when patients are diagnosed with the serious medical problems, we do really recommend that our primary care doctors, especially, refer these patients to palliative care. A lot of times it's nothing but a good roundtable conferences that
Mm-hmm.
all of us are having as providers. So if I need to be, if I'm taking care of a patient who has, let's just say again, a cardiac disease or a cancer diagnosis, I want to be able to have an open conversation with the oncologist, with the
Mm-hmm.
cancer doctor, with the cardiologist, with the pulmonologist, and say, okay, these are the things that we're discussing about. What do you think is going on with the patient? How would you approach this care? these are the medicines that I'm recommending. Do you think it interferes in the care that you want to provide to your patient for your specialty? So there's a lot of open communication, as I call it. I always call palliative care as the purse strings of any medical care. We're always tightening the purse strings because
Mm-hmm.
we're always wanting to make sure that communication is tight between patients and families and the specialists who are taking care of the patient, and that it kind of trickles through down to the grassroots levels for these patients.
So, what do you think should be an ideal response and support from healthcare providers? You mentioned communication is very important. What shall patients and families expect from the doctor and the whole team?
Yeah, I think a lot of times it's very pleasantly surprising to us that patients themselves may have heard of either hospice or palliative care and make that request out to the providers. But this is more a medical thing where I'd say I'd rather that our doctors actually say you're not alone, that we are the ones who actually initiate this conversation,
Mm-hmm.
because we have patients who will Google palliative care and it becomes all about hospice. And then it all becomes about, well, the doctor told me I have treatable cancer, but he referred me to palliative care. And it might look like that I'm dying. And we're like, no, 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 no. That's not the definition. So I highly, highly encourage, of course, our doctors to talk to their patients about it, but
Mm-hmm.
also explain the services that are being offered. Because a lot of patients will approach palliative care with a lot of trepidation and say, oh, I don't really know if I want to be there because I'm not ready to have this conversation yet. Yet when they actually do meet with us and they do hear about the services that we provide, and we spent an ample amount of time with our patients. Our first visits are almost 90 minutes long. So we're spending a long time with our patients where we're exploring every aspect of their lives and
Mm-hmm.
the disease that they're there for. And then when we discuss the care provided, there actually is a lot of sighs of relief. I finally get this, or that they'll walk out of the visit feeling like that something right has happened. And then they'll
Mm-hmm.
message you back with, like, I always joke, 20,000 questions, which is like, wait, what about this? What about this? Which is fantastic because that is exactly the open conversation that we want to have with our patients. So, in the long run, I always tell patients we're in it for the long haul. We're going
Mm-hmm.
to stick with you forever. We may not be always in your lives like every week, but we will always be around. So I see patients anywhere from 2, 3 times a week to two,
Mm-hmm.
3 times a year. And that suffices for a lot of patients, depending on what their needs are.
This is very good because patient knowing that the whole team is with me and doing everything possible to help me will truly comfort the patient and raise the spirit. So, as a patient, I may go to any facility out there, say because of the convenience of location or insurance coverage. Although we expect all the medical providers to be equally qualified, I'm interested to know if there is a way for a patient to explore a provider that matches his or her specific needs and wishes. So, do you have any suggestions for people regarding how to pick a provider?
Absolutely. So I think the most important thing to remember is it is always going to be the patient's choice, right?
Mm-hmm.
About who they want to be with. I firmly, firmly believe that the best medical care that any doctor or any provider can really provide any patient is when they have mutual trust in each other, especially the patient having faith and trust in the doctor. So it's very important for us to have a bond which is one of trust. I always tell my patients, you give me 100%, I'll give you 1,000% back. And that I think is really, really critical in this. So patients need to feel comfortable with the providers. For that, I think the options are they can, one, talk to their own providers who are talking to them about palliative care or hospice. So they can say, well, maybe I want a female doctor, I'd feel more comfortable. Or maybe just from a
Mm-hmm.
cultural standpoint, they might want somebody who speaks their language or understands their culture better, because that can, all of those things actually play a role, right?
Mm-hmm.
And so they can always ask their own primary care doctors or specialists for suggestions, And they can also go on to the websites that our organizations have, which will describe who we are as people. And something about that provider may actually click with this patient, and he might say, well, I really would like an appointment with this doctor. So I highly recommend that you go on websites, read about us, also talk to your providers and say, who do you think will be a good fit for me? That's probably the easiest ways to do it.
Mm-hmm.
Then, of course, if you meet with a provider who you feel is not a good fit for you, there's something that we call a meet and greet in our in our clinics, and the
Mm-hmm.
patient can always say, well, can I do a meet and greet with this doctor? And he can come in and he can interview us and he can decide if this provider is going to be a right fit for me and my needs, and take it from there. Also, if in the end, if nothing else works out and you feel like you left that meeting not feeling very good about this doctor or nurse practitioner that you're meeting, you can always request a change of provider. I don't think that there should be, none of us are really offended by that. I will tell you that up front, only
Mm-hmm.
because all of us want the best care possible. And the best care possible is only possible when you are basing this on faith and trust in each other.
Right. Also, Medicare studies have shown that more than 80% of the people wish to receive care at home. And at the same time, there are people who fail to utilize the services that are available. So, what do you think are the reasons that people don't make use of all the help that is available out there?
Yeah, I always say palliative care and hospice is nothing but simple, good old medicine. It's the grassroots level kind of care, which I feel like hi-fi technology cannot provide patients, right?
Mm-hmm.
I also very proudly say that nobody knows a patient as well as a palliative care or a hospice provider. And that is true because we really explore every bit of a patient's life. So when we start to explore that, patients may have had experiences with their loved ones when it came to hospice or palliative care. They may have had a bad experience,
Mm-hmm.
or they may have had their parents had the same diagnosis as they did. For example, somebody who's young and diagnosed with lung cancer, their mom or dad may have had the same lung cancer. And so I think it brings back a lot of like memories, emotional stress, about those kind of situations. So I think a lot of times so we do in palliative care and hospice, of course, we provide home-based care. So we do
Mm-hmm.
clinic visits, we do hospital visits, we do home visits, board and care visits, nursing home visits, wherever the patient is. And
Mm-hmm.
if it is difficult for the patient to come to us, we will come to the patient. I've had families say that the last time they had a doctor step in their house was about 30 years ago. 1980s, 1990s, maybe even, but since then they haven't had a doctor. So I think it's a big deal for a lot of patients to say, hey, how can I get the best medical care possible for me at this time? So it's a very individual specific kind of medical care that we provide at this time. And most patients, like you're right, would like to have that care provided at home. So what does that mean really for patients? So in palliative care, we're able to have a doctor or a nurse practitioner visit the patient at home, assess the patient, adjust medications. We can order blood tests, and we can have our home health services, which includes nurses, physical therapists, occupational therapists, come home and try to help the patient with getting blood work done, getting their energy levels back, evaluating the home for what it is, and maybe any what we call equipment needs, like a hospital bed, or maybe even a simple ramp, which kind of helps patients walk up to their house comfortably without the risk of falling, or let's just say a shower chair or a bedside commode. Some things that patients are always struggling to think of and
Mm-hmm.
actually don't know who to ask. We are the people. I always tell my patients, if you have a question and you don't know who to ask, just call us. We'll figure it out for you, even if we're not the right people for that issue. So, we're trying to simplify the medical care. We're trying to bring it into patients' homes. And we're trying to tell patients that you really don't need to be in a hospital setting to get the kind of care that you want for yourself. Not everybody wants aggressive medical care. Not everybody wants to be in the ICU of a hospital and being hooked up onto a life support machine. Patients might just say, I'm at the end of my life. I just want to be comfortable. I want to be treated where I am. And if whatever you can bring to me within the home setting, that is fine by me. I don't need aggressively IV fluids, IV antibiotics, dialysis, ventilator care, all of that. I just really want to be comfortable. And that's the perfect setting for hospice, at least, because hospice is a 24/7 service.
Mm-hmm.
So where I always say if a nurse needs to come in at 2 o'clock at night to evaluate a patient who's having any kind of distress, she will come in. So it's a simple phone number you call and say, my dad's having a problem. I've tried these medications. What do I do next? The nurse will come in. Palliative care currently, and it depends on organization to organization, is mainly like an 8 to 6 or a 7 to 5 service. So after hours, we may have somebody who's answering calls, but not all palliative care programs are 24/7 currently. Ours certainly isn't. This may change in the future, but for now, we aren't. But so in that sense, I always suggest call the doctor on call for your
Mm-hmm.
primary care more than anything else. But for hospice, it's 24/7. But both can be home based care. And I love home based care because I say what I see about the patients in their own natural setting, I can never imagine about patients when they actually come to the clinic because it can be a very, very different scenario. You know, we
Mm-hmm.
have patients, I want to be honest, we have patients who look very spiffy and they look so good when they come into the clinic. And if you ask them a question about, how about food? I'm doing great. How about this? I'm doing wonderful. And when you go into their homes, they may be struggling with food. They may not
Mm-hmm.
have the basic necessities in their home. They may be struggling with these steps in the house, which we never talked about in the clinic setting because we never thought of it. They may be struggling with transportation or a simple bath thing, like they can't get into their showers because they might either have a tub and they may have a risk of falling down. And
Mm-hmm.
so we start to, when we look around the house, we start to identify the potential issues that may be going on within the home setting. And when we actually start to recommend and bring in the equipment that the patient needs and the support that the patient may need, whether it's a home health nurse or a therapist or just any equipment or a social worker, it just really, really changes the way the patients actually start to do. They may not even be compliant with their medications because they're forgetful about it. And, so these little things actually are really, really huge in terms of how patients will eventually do in their lives with their diseases, especially long-term diseases like diabetes and heart disease and lung disease. So I love doing home visits for that reason. Of course,
Mm-hmm.
for the pandemic, it's been very different, but we are now getting back into doing a whole ton of like home-based visits now.
Yeah, talking about the pandemic, so many things have changed since last year. So, how do you see the new healthcare environment during this pandemic and also post COVID?
So the pandemic kind of forced us and expedited the need for telemedicine. And I think that a lot of good has come out of it.
Mm-hmm.
Not everybody may agree to it, but I think we were able to reach patients whom we were not able to reach previously because it required a lot of effort from the patient on the patient's side to actually come into the clinic. Now we're talking about our 80-year-olds and our 90-year-olds who are one, either
Mm-hmm.
living home alone, so may have transportation issues, two, have so much weakness from their medical problems that they might actually, it might be like a 4 hour long process by the time they take an hour or two to get ready and somebody actually brings them to the clinic, has a visit with us and actually goes back and settles them down. They're not just exhausted, but they've pretty much spent half the day for a 1 hour visit in the clinic. And so, for a lot of these patients, actually, telemedicine became a very quick and efficient way of connecting with the doctors, especially patients that we've known over a period of time. So, we can actually see them and we can talk to them and we can see what's going on within their home settings. So, I do have to recognize that not every patient is technologically savvy. So, we've had those challenges. For that, we've tried to come up with innovative ways, provide iPads to patients for short periods of time, just so
Mm-hmm.
that they have a way of connecting with the doctors. But I do think that in going forward, with hopefully the pandemic getting better and better over time, at least in the US, we will have both an equal combination of telemedicine and clinic visits, because we would love to see our patients. We would love to provide hands on medical care. And a lot of times we are not able to do that just because we're just seeing the patient over a video call for the past year. So I think going forward, it will be a combination of both.
Mhm.
And I have to say that medical organizations are definitely getting better and better when it comes to technology now.
Which is good because now we can have a hybrid model, best of both telehealth and in-person meetings. So we can achieve the speed by utilizing the technology, video calls and all that. And at the same time, whenever required, we can see patients in person.
We've had patients who've moved out of this area in the past year, but because we are allowed to practice in the state of California, no matter where our patients are, even though they're
Mhm.
moved out, we've been able to access them, which has been wonderful. Yeah.
We are coming towards the end of the show. So, what advice do you have for people to plan the best course? Because when the bad news comes, people at times lose hope and they even stop asking for help. So, how can we encourage people to seek all the wonderful help that is available out there?
Right. I think that one, there needs to be still a lot of education and awareness about palliative care and hospice, number one.
Mhm.
I think it does always start with the primary care doctors when it comes to giving bad news to a patient. I think we always look forward to their support, and they should be the ones to recommend that. I know a lot of our specialists already do. So, especially our oncologists are very, very good about referring patients to palliative care. I would say that combined with community educations and the providers themselves providing the idea of what palliative care and hospice can do for them, that's a really, really good place to start. When they're overwhelmed, patients are almost blocking off all the information that is coming to them. So, we say this that in a conversation that we may have had with any patient, while we as doctors feel like we covered most of the data, pretty
Mhm.
much the long story short of it is that patients retain only about 10 to 30% of what you actually told them. And so that can be a lot of information for one visit, especially when you get bad news of any kind, right? It just kind of
Yeah.
stops there. Like you have stage 4 lung cancer, or your heart is not working anymore the way we were hoping that it would be. Everything just stops at that line, and rarely do patients actually absorb and really think about what the doctor is saying next. Having said that, I really, really appreciate patients who, I feel like every patient is very intuitive about what's going on with their bodies. And I always tell my patients, you know yourself best. I've only just met you. So I really want to follow your cue, and
Mhm.
I want to walk your walk with you. I don't want you to walk your walk with me, because I want to do what you would want for yourself. So I want to be the patient's spokesperson for other doctors and other providers who are caring for this patient, and say, this is what he or she wants, and this is what we can do under the circumstances. A patient always has the right to decide how much they want in terms of medical care. Not every kind of aggressive medical intervention is for everybody. Sometimes less is better. Patients actually do better when they have less than what is available to them. What I mean by that is, not every patient needs to go through dialysis. Not every patient needs to be on life support. And so, even though there are all these options available, and we live in the Bay Area where everybody is so tech savvy anyways and knowledgeable about everything, I still say we're still human beings at the end of the day, and we need to follow our own body's cue as to what it might be able to tolerate. Sometimes when you choose too much of an aggressive approach, you might actually end up shortening your life in that. So
Mhm.
we're always kind of wanting to provide knowledge about balancing both a quality and a quantity of life in such patients. The one thing I always, always, always want my patients to remember is, even though a doctor can come in and say, well, you have this option, this option, this option, this option, not every option's for you. The one option that every doctor should provide to you also is the option of no treatment. right? So you always have the option of choosing a more comfort focused approach and not going through any further hospitalizations or no more treatment, which might actually reduce your quality as well as your quantity of life. A case in point is chemotherapy. A lot of patients will go through chemotherapy because they feel it's going to keep them alive. But at
Hmm.
some point, their bodies are so weak and the chemotherapy has only gotten stronger and stronger over time that that chemotherapy might actually hurt them and might actually result in them being more immunocompromised with more infections, more weakness, and actually might actually cause them to pass away sooner than they were expected to. So there are studies to this regard, and there are studies which show that when you choose palliative care, because we're able to provide you the education and the knowledge to make the best decision for yourself, patients actually tend to live longer than they were expected to.
Great information, Dr. Multani. I want to thank you for your time today. It has been a pleasure having you.
Thank you so much. Thank you, everyone.
So we have these educational programs at least once a month, and one can see the recordings on the Facebook page of San Francisco Bay Area chapter of NAIPC. Over to you, Sarah.
Thank you so much, AJ, and thank you, Dr. Maltani. I love the presentation being focused around patient-centered care, and making sure people are educated to make their own choices. And I think it's just equally important to make sure people can talk about this at any point in time, don't have to wait until the last minute. And when you get to know some of these things and you start to reflect on yourself, I think it's so important to just remember to share your choices with your durable power of attorney, your friends and family, because we plan for so many things in life, but I often think that a lot of us don't plan for one of the most important things, which is still part of our life, being the end of our life. So I really appreciate everything you've shared today. And we are here as a resource to help people kind of navigate all these choices, because I know it's so overwhelming sometimes to go online. And I think for myself, I find, again, building trust, right? And getting to know people that interact with a lot of people that work with various services can give you a lot of information that you don't necessarily get from numbers online. So thank you again for everything. We hope that maybe you'll come back and talk to us again.
I would love to. Thank you so much for having me. Thank you.
Thank you.